Well, hello and welcome to part 2 of surgical pathology of the ovary. Today dealing with germ cell tumors. This is a resident level discussion and aimed at the foundational principles that residents need to know to pass the boards and to practice effectively. Note that it's been updated since this target date here. Our objective, as previously, is to properly classify the germ cell tumors of the GYN tract, explain some of the differential features that are involved, and understand how those features may impact therapeutic choices and particularly relate to staging issues. So we'll begin right off the bat with Dysgerminoma, the most common malignant germ cell tumor that we encounter in the ovary. 5 to 10% of cancers in the first 3 decades of life, typically associated with some sort of abdominal mass, elevated LDH, and may have other hormonal markers as well, such as HCG, and potentially elevated calcium. There is a small association with gonadal dysgenesis or gonadoblastoma, and some of these will be bilateral. Now, we're going to be dealing with a number of stains today in these lesions, and Dysgerminoma has several key markers that are not usually found in other tumors: OCT4, D240, SAL4, sometimes CD117, LIN28, but usually CD30 negative, as it is not a keratin-producing malignancy. So here's what it looks like grossly: a nice lobulated, fleshy tumor with a pale appearance, and that corresponds to the microscopic appearance of very dense sheets of neoplastic cells, fairly uniform, delicate fibrovasculature manifest between these nodular areas of tumor. And as we would expect, similar to that seen in the testis, we will find a smattering of lymphoid cells sprinkled along those vascular channels. And you see the nuclei fairly uniform, often with a prominent central nucleolus and clearing surrounding that. They can have a somewhat more eosinophilic appearance and maybe even a pseudoglandular pattern, as seen here, with cells lining up along the periphery of these spaces, and you'll note the more eosinophilic cytoplasm in this case. Sometimes that cytoplasm will be very clear, and you'll see both a clear cell pattern with maybe hobnail type cells resembling clear cell carcinoma, or perhaps even a cord-like pattern resembling some of the sex cord stromal tumors that we've discussed previously. On rare occasions, you can find syncytial trophoblastic type cells, giant cells, and so forth. And these are usually associated with the presence of serum HCG. In fact, if you have elevated serum HCG, the clinicians will often ask, did you find syncytial trophoblastic cells, or is there a mixed germ cell component that you haven't discovered? So it is important to document their presence because that can help to correlate with the clinical and serologic findings. Another pattern that's occasionally seen is this sort of intratubular pattern with very eosinophilic stromal luteinized cells. You can see how this sort of a pattern could easily fit into the realm of a Sertoli-Leidig tumor, for example, and create some potential confusion there. Here's a little bit more granulomatous reaction to these lesions that can sometimes mask the presence of the malignant cells if the granulomatous reaction becomes prominent. So based on these things, you can imagine that our differential diagnosis might include things like clear cell carcinoma, undifferentiated carcinoma, small cell carcinoma with hypercalcemic type, large cell lymphoma occasionally, and certainly solid pattern yolk sac tumor, embryonal carcinomas, and so forth. And that doesn't include some of the benign lesions such as granulomatous or orchitis and those sorts of things that could be considered in the differential. Going on to the yolk sac tumor, second most common lesion. This accounts for a significant portion of the malignant germ cell tumors, 1 in 5, and is usually a young adult period of life neoplasm associated with pain and very often elevated AFP. Usually in isolation, not present with HCG unless it's combined with a mixed lesion. Now, a significant portion do have other germ cell elements such as Dysgerminoma or maybe a mature teratoma like a dermoid. Of course, we recognize the Schiller-Duval bodies as the most sought after feature and characteristic feature, but only present in about 1/5 of cases. And yolk sac tumor has so many possible patterns. It's really a quite remarkable and diverse lesion. Eosinophilic PAS positive hyaline bodies are common, but again, not specific and not uniformly present. The immunohistochemistry will usually be AFP positive, glypican-3 positive, Lin28 and SAL4 positive, but notably here will be negative for OCT4, CD30, CK7, or epithelial markers. And there are several other variants that can be seen commonly. The polyvesicular vitelline variant can be a difficult one to recognize. Hepatoid variants also somewhat confusing at times, as well as the more glandular lesions. The differential, because of this morphologic heterogeneity, is again broad, including clear cell carcinomas, sex cord stromal tumors, endometrial adenocarcinomas, even steroid cell tumors, with abundant eosinophilic cytoplasm. In terms of prognosis, the patients actually with stage 1, they do very well. And then those things drop proportionately as the stage advances. AFP is a useful serologic marker for tumor regression or progression. And other adverse markers include advanced stage, older age, and liver involvement. Here's a nice gross image showing this very variable morphology: cystic, spongy, solid areas, hemorrhagic, necrosis, quite a varied cut surface here in this fairly bulky tumor. Here's a fixed specimen showing, again, this very spongy pattern with variable size cystic spaces, and that corresponds to this kind of microscopic appearance where we have a very sieve-like pattern with just very delicate interconnecting tails of tumor with cystic spaces and peripherally pushed nuclei. Here at higher magnification, you can see these characteristic eosinophilic droplets, hyaline droplets, and the characteristic nuclear features, again, somewhat pleomorphic, a prominent nucleolus, and malignant nuclear features with mitotic activity and so forth. We'll go on now to the next slide and show you, I guess I showed you that slide twice. Okay, so there it is twice in a row. Well, you can also have a more delicate labyrinthine or maze-like pattern, as we see here, with wandering cords and columns of cells through this background. Here you can see how this might be resembling clear cell carcinoma or other neoplasms with a more glandular pattern. Occasionally, you'll get a very micropapillary pattern like this, which might even be confused with serous carcinoma in some settings, or also with clear cell carcinoma. Here's the higher magnification and shows the characteristic Schiller-Duval body with the nice central vessel surrounded by a halo of neoplastic cells, then another clear space and peripheral neoplastic cells again in that characteristic pattern. We can have solid patterns, as you can see here, somewhat resembling Dysgerminoma, as you can imagine. Again, not with the very great lymphoid population, but that's not always present in Dysgerminoma either. And here's the more polyvesicular vitelline pattern. This can be very deceptively benign because the neoplastic cells can be very attenuated around the periphery of these cystic spaces. And here, a more adenofibromatous appearance, where the cytologic atypia of these cells is, again, somewhat difficult to pick out amidst this more fibrotic, fibromatous stroma. So serous cystadenofibromas, except for the fact that we are lined by yolk sac type tumors and would have an elevated AFP. Here's a more hepatoid variant, again with abundant hyaline droplets, but you can see the more solid appearance and the more oxophilic type cytoplasm, the pseudoglandular appearance of some of these nests. And then here a very unique pattern, the endometrioid pattern, but this is an endometrioid pattern with sort of an inverted appearance. And notice that rather than having the piano key type of appearance with the nuclei at the base of the cell, here they're at the apex with the cytoplasmic vesicles surrounding the central vessel, or the central core of the papillary structure. Embryonal carcinoma, going forward, is quite uncommon in women as opposed to men. These, again, are younger patients who have adnexal masses and may have multiple elevated serum markers because there may be syncytial trophoblastic elements or yolk sac elements or other features. This lesion is CD30 positive, as well as having OCT4, SAL4, and Lin28 markers being positive. Differentially, it falls into the realm of other germ cell tumors versus just a very poorly differentiated or undifferentiated carcinoma. Occasionally juvenile granulosa cell tumor, although it's usually more pleomorphic and clearly malignant compared to juvenile granulosa cell tumor. And some poorly differentiated Sertoli lytic tumors can also look like this. Here you see this high-grade malignancy with slit-like spaces, quite malignant appearing nuclei, and occasional mitotic figures. Here's an area with the syncytial trophoblastic cells, which stain nicely with HCG, and that can be useful if you have a differential concern. If you've been searching and haven't been able to find this syncytial trophoblast, potentially staining for them can help to bring out their presence. Now, an unusual and uncommon germ cell tumor is the polyembryoma. This may be rather just the most immature of immature teratomas, but this is a rare tumor that presents in very young patients, and again with elevated serum markers, characterized by these embryoid bodies, which I'll show you in a moment. And this is often seen, if it's present, as a component in a mixed germ cell tumor, where you'd like its presence to be greater than 3 millimeters in size. So here's the gross appearance, a very hemorrhagic tumor with some more solid areas, somewhat spongy and soft, friable appearing. And here's the characteristic polyembryoma embryoid bodies, as you can see, forming a plate between these two cystic spaces, very cellular plate between two cystic spaces, and surrounding immature mesenchymal type tissue, hence the belief that it may be a more teratomatous type of lesion. Now, another also uncommon germ cell tumor is choriocarcinoma of the non-gestational type, that is occurring not in association with pregnancy, away from the placenta or uterus. Again, this can sometimes be present in mixed germ cell tumors and should be recognized and commented on when present because of the hormonal association. It includes in the differential, of course, gestational choriocarcinoma, other germ cell tumors with syncytial trophoblast, and rare other epithelial tumors derived with some tissue-trophoblast type tissue. And as typical for gestational neoplasia, it often responds nicely to chemotherapy. Here's an example occurring in the ovary of this very spongy, very hemorrhagic appearance that you would expect. And under the microscope, you'll see a very high-grade malignancy, a lot of pleomorphism or seeming anaplasia, but that's really the syncytial trophoblastic cells that you can see often surrounding or subtending the trophoblastic malignant epithelial or malignant cells, cytotrophoblast. Okay, well, let's go on now to the teratomas. Of course, this is an area which we have all seen, or you will all soon see. Mature cystic teratomas are very common, occurring in the reproductive years, of course, and accounting for about, almost 2/3 of benign tumors. Not infrequently are bilateral and may often be asymptomatic or unsuspected. But when they become complicated with torsion or perforation or other sorts of changes, including potentially paraneoplastic syndromes such as encephalitis, they can come to clinical attention quite quickly and emergently. Here's the characteristic appearance: a cystic space, pigmented areas, hair, sebum, maybe bone or teeth. So you can see the very varied appearances that typically are seen with this. Another lesion with purely hair and sebum, very little cystic tissue, maybe a little bit of adipose tissue at one edge here. And under the microscope, they're quite interesting. Nothing like normal ovarian tissue, but rather replicating normal structures elsewhere with sebaceous glands, cartilage, epithelium of varying types, and not infrequently, neural tissue. So mature glial tissue over here on the right, choroidal type tissue, including psalmomatous calcifications, cortical and maybe even cerebellar type tissues in some foci. Here's another feature that can be seen, which is a inflammatory lipogranulomatous reaction to these lesions. The sebum and the cysts, when they rupture, can create quite an inflammatory reaction, either within the wall or more disseminatedly within the peritoneal cavity as well. Immature teratomas, in contrast to the mature type, are relatively uncommon, just forming a few percentages of the lesions that are seen. They may have low-level AFP elevation, and a fair number will have some sort of implants within the peritoneum most commonly. These tend to be somewhat bulky and fleshy with mixed areas of solid and cystic characteristics. Of course, the diagnostic feature is the presence of embryonic, not simply immature tissue, that is usually predominantly neuroectodermal. So finding neuroepithelial rosettes or neuroepithelial tubules and mitotically active glial areas, this is what you need to classify something as a immature teratoma. The grade 1 tumors typically have only rare foci of this, less than one low power field in any slide. Grade 2 tumors have slightly more, and grade 3 tumors contain 4 or more low power fields of immature neural tissue on a given slide. Now, those are rather loose criteria, and so there's a degree of subjectivity involved with this, and hence it may be prudent to compare your grading with others who have had perhaps more experience. Implants, particularly immature tissue implants, are usually glial tissue and so-called peritoneal gliomatosis. But it's important to sample these and to detect any epithelial elements. Quite unusual is these genetically have been, at least in some studies, found to be genetically unrelated to the teratoma, to have a different phenotype and genotype. The differential diagnosis, of course, is mature teratoma. Solid teratomas, ovarian neuroectodermal tumors, which can occur but are rare. Malignant mixed Mullerian tumor, but that usually is a much older age group. If we're able to achieve a complete resection, the patients generally will do well, and chemotherapy may be required for high-grade lesions, especially those with immature implants. Now, here's a nice image of one. You see this glistening type lobulated tissue with sort of a solid, fleshy appearance. And under the microscope, we would look for these very cellular areas of mitotically active glial tissue forming small tubules or rosettes, and in company with other immature tissues such as immature cartilage or immature mesenchyme that we see elsewhere. Here's a high magnification view showing the tubules, the little rosette formations, and here, and the immature glial components. In the peritoneum, these can be quite mature. This is peritoneal gliomatosis with these rounded nests. Now, sometimes the differential here might be sort of a stromal type endometriosis, or potentially even endometrial stromal tumor could enter into the differential for this sort of a lesion. But immunohistochemical staining should very quickly clarify that differential consideration. Here's an immature peritoneal implant. As you could see, very cellular tissue, not much in the way of a neural tube or rosette formation, but mitotically active and quite cellular, that would create some concern for malignancy if found in the wrong location. So let's go on and talk about monodermal teratomas. In other words, germ cell neoplasms that have only one germ cell layer. Struma Ovarii is the most classic type, typically just defined as thyroidal tissue present in the ovarian parenchyma. This usually is presenting in older adults and may have variable microscopy because of the diversity of findings that one can see with thyroid tissue. And so you can see some of the same thyroid diseases in the ovarian component that you might see elsewhere: thyroiditis, nuclear atypia, and various kinds of neoplasms from adenoma to carcinomas. Here is a nice example, and this is one that's potentially associated with a mature teratoma over here on the left. And here you see the very gelatinous follicular tissue on the right that is characteristic of struma. Here's another example with a more mature sebum and hair over on the left, and this very gelatinous, solid and follicular type parenchyma on the right. Under the microscope, of course, it's going to look like thyroid tissue, and you can have variable cellularity, large, small follicles, just as we would see in various lesions in the thyroid, including small nested patterns, widely separated. And so differential considerations, neuroendocrine tumors, second cord stromal tumors might enter into the differential considerations with this as well. Immunohistochemistry can be of value if need be, if you have a solid version, and here's a nice solid version that demonstrates positivity with thyroglobulin. And so this might be confused with a granulosa cell tumor or with other neuroendocrine tumors as well as struma. Clear cell change also comes into the possibilities here, and you can see where the differential of those sorts of clear cells might lead to germ cell tumors, to clear cell carcinomas, and even some serous tumors. Some of these lesions can become cystic, just like in the thyroid, with degenerative and hemorrhagic changes. So sampling these lesions and detecting the very low cuboidal type of epithelium that will line these lesions should then lead you to think of and consider that this is not just a simple serous lesion potentially. These sorts of lesions that is in the differential, and particularly in some settings, you'll want to make sure that you have not mistakenly called this a serous cyst. Immunohistochemistry, if need be, can help to differentiate between the simple low cuboidal serous type epithelium versus the appearance with a thyroglobulin positive lining and hence a cystic change in a struma ovarii. So what are some of the other lesions that might have colloid or colloid-like substance besides struma? Well, endometrioid carcinomas can, mucinous carcinomas can, clear cell tumors, Sertoli-Leidig tumor, juvenile granulosa cell tumor can have a colloid-like substance, yolk sac tumor occasionally, and then less commonly pituitary adenoma in a dermoid or small cell carcinoma, the hypercalcemic type, and various even less common lesions, metastatic tumors, and pregnancy luteoma as the benign lesion. Now, thyroid tissue is not immune to developing carcinomas in the ovary as well. These are uncommon, but they do occur, and occasionally they will obliterate or overrun any residual benign struma, and thus can be difficult to differentiate from unusual carcinomas. So immunohistochemistry, cytogenetics occasionally can be helpful. One caveat here is that follicular carcinoma, differentiated carcinoma of the follicular type, would require evidence of invasion or metastasis. So you're not going to be able to really easily demonstrate a minimally invasive follicular carcinoma arising from struma ovarii. Here's an example of papillary thyroid carcinoma that has arisen in a struma ovarii. And you can see the typical cytologic nuclear clearing and orphananii characteristic with occasional inclusions and nuclear grooves. A more deceptive appearance might be something like this, where it has a more trabecular pattern. It's more solid. And so some of the variants of papillary carcinoma, like the tall cell variant or the other columnar cell variants, can be difficult to distinguish from other primary ovarian tumors. This, for example, as it says here, was initially diagnosed as a granulosa cell tumor until it was found to have thyroglobulin on immunohistochemical staining. So carcinoid tumors are another lesion that one can encounter in these monodermal teratoma lesions. As we talk about these neuroendocrine tumors, it's important to recognize that they can occur in conjunction with a struma, for example, and that's why it's a natural branch point, or they can occur as a component of a dermoid or mature teratoma. The insular type is the most common and is usually stage 1 in older adults. This is more commonly presented as a nodule within a dermoid and would have a characteristic microscopy of other neuroendocrine tumors here, a solid and microglandular acinar pattern. A more insular appearance like these islands of puzzle pieces fitting together with the characteristic nuclear features of a neuroendocrine tumor, the salt and pepper nuclei, minimally prominent nucleoli, and very granular cytoplasm. A trabecular carcinoma is a morphologic type that is seen less frequently, however, have all been seen to be benign. So it may be a meaningful morphologic variant. And then, as I mentioned or alluded to, the Strumal carcinoid has associated thyroid tissue, but rarely has the carcinoid syndrome, whereas the insular carcinoid may be more frequently associated with the carcinoid syndrome. This has both components either admixed or adjacent to one another, and hence immunohistochemical staining can be important to be able to differentiate and to separate these. For example, this field here, is this all struma? Is this all carcinoid? It's really quite difficult to tell. And when we look at the immunohistochemistry from this lesion, you can see that the patterns can be deceptive. Here's the thyroglobulin staining on the right. Here's the chromogranin staining on the left, and you see that it's a diversity of patterns that intermingle with one another in this lesion. Mucinous carcinoids also can occur in the ovary and create a whole new set of challenges. This is fortunately the least frequent neuroendocrine tumor in the ovary, but the overlap with low-grade mucinous lesions from the appendix, as well as with mucinous lesions primary in the ovary, is challenging, especially if these become bulky and so forth. Looking at the microscopy here, you can see how this could be very easily confused with a gastrointestinal type of primary tumor, potentially from the appendix, a low-grade lesion, a lot of pools of mucin here, and it wouldn't be recognized unless we had detected the neuroendocrine features of this tumor, usually with immunohistochemistry. Grading these tumors is probably an item in flux still. I think in general, we're trying to move towards a more unified grading system for neuroendocrine tumors. And so using the well-differentiated tumor, grade 1, 2, and 3 may have some merit. However, you'll still find things in the literature which classify as atypical carcinoids or atypical neuroendocrine tumors of the ovary. And then carcinomas arising in mucinous carcinoid, again, another lesion that is probably going to change nomenclature over time. So if you encounter a lesion like this, best to consult carefully with the most recent WHO version to make sure that your usage is apropos of the current thinking. Other neuroectodermal tumors can occur as monodermal teratomatous lesions in the ovary. These are very rare, but would correspond to the things that you would see in the CNS. Again, these cover a rather wide age range and a wide variety of differentiations, but most of them would have some component of teratomatous lesions. So here, for example, a picture of a neuroectodermal tumor, a nice tubular formation, a little rosette type of appearance around here. This is an ependymoma, but this could have been from the spinal column, the cerebellum, or as in this case, from the ovary. Neuroblastoma also can occur as a primary tumor in the ovary. Low grades, highly malignant, a small cell, highly malignant tumor with a somewhat fibrillar background, and varying degrees of differentiation, of course, would be expected to be seen, as we see here with a little more differentiation, a more fibrillar change, and some pleomorphism, more anaplastic type of tumor cells that might be seen in a anaplastic glioblastoma, high-grade mitotic figures as seen here. These will be rare tumors and probably things that most general pathologists would consult with a recognized expert for assistance. And then another vexing challenge, particularly in terms of sorting things out, mature teratomas with secondary somatic tumors. So this essentially is a mature cystic teratoma with some component that has developed a somatic type neoplasm, whether that's carcinoma or melanoma or lymphoma or sarcoma or some other variant on this type of lesion. So I'll show you a gross image. Here we see the spongy exophytic squamous carcinoma, which is the most frequent type that we see, arising in a cystic teratoma with hair and other benign elements associated with it. We can see here it was a somewhat spindle-shaped squamous carcinoma with some transition here with this sarcomatous component. Other lesions that we can see are mixed germ cell and sex cord tumors. These can be have varying underlying features. Gonadal dysgenesis is kind of the feature of note, and tend to be much younger patients, usually children or young adults. Sometimes there'll be a normal karyotype, but sometimes there'll also be an extra portion of the short arm of Y that contains this TSPY1 gene, which seems to be critical for normal gonadogenesis. A gonadoblastoma is one of these tumors that can occur in this setting that has, in its pure form, usually a small size, oftentimes even just microscopic, but may have some overgrowth of a germ cell type lesion and tend to be bilateral in this setting. Of note, the contralateral gonad contains gonadoblastoma in only a third of the cases, but it may contain a malignant germ cell tumor, such as a Dysgerminoma, without evidence of residual gonadoblastoma. So you find one of these, and you really want to make sure you've looked very, very carefully at the other gonad, and oftentimes excise it prophylactically. Microscopically, we'll usually see some discrete aggregates of some composed admixture of germ cells and small cells of the sex cord type. Germ cells tend to be similar to those that we see in Dysgerminoma and have the staining characteristics that we would associate with that, whereas the sex cord type cells will be surrounding these lesions and stain differently, usually with the sex cord stromal markers like inhibin, calretinin, but may also stain with AE1 or AE3. So here's a gross image of a dysgenetic ovary, and it doesn't project really well here, but there are small white calcific bodies, quite calcific areas in these ovaries that represent the foci of calcification associated with this mixed Dysgerminoma and sex cord tumor. So here we can see we've got these Dysgerminoma type cells in these nests, and you can see some surrounding admixed cells here, sort of like intratubular germ cell neoplasia in the testis, but occurring here in the ovary. And then we'll get these calcifications in association with this as well. So this is, again, an unusual setting and quite a distinct set of possibilities. Here we see the same process again, the sex cord stromal tumor forming the periphery of this lesion with small tubules, and then the admixed germ cells, malignant germ cells within that lumen. And then here outside of this, we see areas where the Dysgerminoma is actually invasive in the stroma without the subtending sex cord stromal elements. So the differential diagnosis includes Dysgerminoma as a pure form or sclerosing sex cord tumor with annular tubules, the scatat, which we did a video on that a while back, or just unclassified germ cell sex cord stromal tumor. You may not be able to classify. And gonadoblastoma may be present in some of these lesions. So here's another image of this mixed germ cell stromal tumor with nests of cells composed of germ cells. We see these large tumor cells here in this sort of cord-like area that looks a lot like Sertoli cell tumor or maybe a Sertoli-Leidig cell tumor. So here we are. We've made it to the end of the presentation. I hope you'll like our presentation and subscribe. Send us your comments. We always welcome those. And please feel free to share this video with your friends or colleagues as you may see fit. And we'll hope to see you again at a future time. And thank you for joining us.